So, shall we start?
Sure.
Hello, everyone. Thank you for joining today's session on your favorite channel, Cancer Reach. Cancer Reach is an initiative by our very own tumor tamer, Dr. Krishnamani, to spread awareness about the cancer and to help patients and caregivers access the right treatment at the right time. Hepatocellular carcinoma, or HCC, has long been a challenging cancer to treat, but recent advances in molecular targeting and immunotherapy have truly transformed the landscape, offering new hope and improved outcomes among these patients. Today, we'll explore how these evolving treatment strategies are reshaping the clinical practice and what this means for the future of liver cancer care. Joining us today is none other than Dr. Krishnamani, one of the most respected voices in the field of oncology. For over a decade, he has been associated with AY hospitals here in Hyderabad. He has expertise in treating solid tumors, hematological malignancies, and also dealing with oncological emergencies. With prestigious international fellowships and leadership positions across some of India's top cancer centers, he combines deep clinical expertise and a truly global perspective on cancer care. His contributions extend beyond the hospital walls, shaping cancer care policies, advancing treatment protocols, and driving impactful research. Above all, what patients and families value most is his compassionate and empathetic approach, which has made him not just a doctor, but a trusted companion in their cancer journey. Welcome to you, sir.
Hello, everyone. Welcome to Cancer Reach. Cancer Reach is an initiative to spread awareness on cancer. Our focus is usually on patients and their caregivers. So that's why we keep things very simple, though the topics are extremely complicated medically. And as you said, today we'll be discussing on hepatocellular carcinoma or primary liver cancer and how certain recent treatments have changed the way we look at this disease in advanced cancer cases.
So, sir, can you start right from the start? Can you tell us what is hepatocellular carcinoma and what are the causes for it?
See, hepatocellular carcinoma is cancer which starts in the liver or primary liver cancer, to put it very simple. People have breast cancer, people have colon cancer, people have stomach cancer, people have lung cancer. That cancer can spread to the liver. That is not hepatocellular carcinoma. That is metastasis from some other cancer or spread from some other cancer. So somebody with a lung cancer with disease to the liver means the cancer has spread to the liver. It is not starting in the liver. Hepatocellular means it starts in the liver. Okay. The common causes: chronic alcoholism, hepatitis B chronic infection, chronic hepatitis C infection, something called non-alcoholic fatty liver disease because of obesity, diabetes, etc. So we see this fatty liver and all that we keep reading, right? That is one part of it called non-alcoholic. Those patients don't take alcohol, but they have fatty liver. That can grow into something called cirrhosis. Cirrhosis is the end stage where where the liver shrinks. Normal liver shrinks. That is cirrhosis. And it becomes nodular. It becomes bumpy. When you do an ultrasound, that liver is bumpy. The surface is not smooth. And it shrinks. That is cirrhosis. So anything which leads to cirrhosis, what are the common causes of cirrhosis? Chronic alcoholism, chronic hepatitis B, chronic hepatitis C, and non-alcoholic fatty liver disease. These four causes commonly lead to cirrhosis or shrinking of the liver. In a cirrhotic liver, you develop HCC or cancer. So those are the common causes.
Sir, how is the patient pool for this disease, more in women or in men, and which age group is commonly affected?
Men outnumber women by a number of 4:1. Uh, in countries where there is high alcohol intake, that is the cause. In countries where hepatitis B vaccination is not mandatory, that is the highest reason. And in countries like the developing countries where obesity is so common, non-alcoholic liver disease also adds up. And men are commonly affected. To develop HCC, it will take time. It's a chronic process. Your normal liver should become a cirrhotic liver and that should develop cancer. Usually it takes 20 to 30 years. So generally you see patients above the age of 50 years.
Sir, are there any warning signs and or symptoms that patients should look out for?
There is no specific early warning sign. Patients will have non-specific symptoms like jaundice, weight loss, loss of appetite. They may have swelling of their limbs, which means that their liver is not working well. They may have swelling in the tummy because of water accumulation or ascites, we say. That is because when you have liver cirrhosis, it is not specific to liver cancer. Even in liver cirrhosis, you can develop ascites. Even in kidney problems, you can develop ascites or pedal edema, we say. Pedal means foot, edema means swelling. So, weight loss, loss of appetite, swelling of the abdomen, swelling of the feet, presence of jaundice, poor intake. Okay, these are all the common symptoms of hepatocellular carcinoma, but they are non-specific. They can be seen even in non-cancerous conditions or other cancers also, or other systems which are involved, like maybe the heart or the kidney also.
So, will I be correct if I say that hepatocellular carcinoma is a lifestyle induced cancer rather than genetics having a role to play in it?
So you remove alcohol, you're removing one important cause. You vaccinate yourself against hepatitis B, you are removing one important cause. You practice safe sexual practices and needle sharing and all that is not there, tattooing and all that, if you don't share needles, then hepatitis B, C infections are not there. You maintain a good body mass index, uh, walking, your yoga, exercise, you are slim and thin, not very obese, grossly obese, then risk of fatty liver comes down. So obviously it's a lifestyle related thing.
Sir, can you walk us through the diagnosis for these patients?
So hepatocellular carcinoma is one disease which differs from other cancers. So first of all, when you talk about diagnosis, clinically, how are you going to diagnose? These are the symptoms. Generally, a patient has an ultrasound first. In the ultrasound, in the liver, you will see some spots or lesions, we say, and a shrunken liver sometimes. The best test to image is either a CT scan, we call it with triphasic protocol, we say, or a contrast enhanced MRI of the abdomen. Do either of those two tests. Then you can diagnose a patient with hepatocellular carcinoma. On the imaging report, they will give something called a LIRADS report. LIRADS. For breast, we call it BIRADS. So the radiologist on a score of 1 to 5 will say, I am seeing something in your liver. It is LIRADS 1, LIRADS 2, or LIRADS 5, or something like that. So you will do imaging, usually starts with an ultrasound, but the best is a triphasic CT or a contrast MRI. It is reported on a LIRADS scale. You will do a blood test called alpha fetoprotein. It is elevated in hepatocellular carcinoma, but not all cases it may be raised. So a normal alpha fetoprotein doesn't mean you don't have liver cancer. Number one, liver alpha fetoprotein can be elevated if cancer spreads from other organs to liver also. So it is not specific for liver cancer. It can be elevated even in normal conditions like hepatitis, etc. So in it can be elevated in liver cancer. It can be normal in liver cancer. It can be elevated in non-liver cancers like ovarian tumors. We call it yolk sac tumor, or spread to the liver from other organ. It can be elevated even in cirrhosis or hepatitis. But so it is not a 100% foolproof test, but it's a what do you say, a companion test. If it is very high in thousands and 10,000s, you can say, boss, you have cirrhosis, you have some liver lesions, alpha fetoprotein is more than 40,000. So most likely you have liver cancer. Another blood test is called PIVKA, PIVKA. If that is elevated with alpha fetoprotein, that is more specific. Finally, biopsy. So why is liver cancer a bit different? Not all patients need a biopsy. What did we always say on Cancer Reach? Cancer means you need biopsy. Tissue is the issue. Here, if you have LIRADS 5, you can get away with a biopsy. If alpha fetoprotein is extremely high, with a classical radiological picture of liver cancer, get away with a biopsy. But if you have a doubt, if it is no cirrhosis, if alpha fetoprotein is normal, in India, there is another common disease which comes in the liver called cholangiocarcinoma. So if you are worried that it could be cholangiocarcinoma, then do a biopsy. So my tests to diagnose are a triphasic CT abdomen or a contrast MRI, an alpha fetoprotein and a PUCA as an additional blood tests, a biopsy if required. If the imaging is not classical of HCC, additional blood test like complete blood picture, renal function, liver function test. In liver function, you look at liver enzymes, bilirubin, whether you have jaundice, and something called PT-INR to see if the liver is secreting or producing clotting factors properly. Because if the liver doesn't work properly, clotting factors are not produced. If your clotting factors are not there, your blood does not clot, you will bleed. So clotting factors, enzymes, bilirubin, all this is done in a liver function test. So these are my tests to diagnose somebody with HCC and to look at and assess the liver function also. Suppose somebody you are taking up for surgery, you have to also do a liver elastography, we say, to see how good is the no other liver which will remain after surgery. Uh, that is, this is the liver. You are going to remove this part. This liver should be able to withstand and work on behalf of this, which is going to be removed. So that you will decide before surgery to see how good the other liver is, which is going to be saved after surgery or left behind. Finally, most patients with liver cancer will need an endoscopy to see if they have something called esophageal varices. Varices means they are thick blood vessels in the food pipe. If you have cirrhosis, these blood vessels will become thick. You have a risk of bleeding, vomiting, in blood vomiting rather. So you will do an endoscopy, look at that blood vessels. If it is very thick, the gastroenterologist will make it thin and prevent bleeding in future because there's a risk of blood vomiting. So these are all the things you should look at. Finally, the general condition of the patient and what comorbidities. Is he diabetic, hypertensive, dialysis patient, bypass patient, stent patient? Is he on blood thinners? So this is all you have to look for.
Sir, are there any specific categories to stage the patient, like any patient with hepatocellular carcinoma?
Yes. So there are multiple methods. One is called a Barcelona method, where they divide patients into very early, early, intermediate, late. Very early means it's a very small lesion, less than 3 centimeters. Early means there are 2 or 3 lesions. Intermediate means it is in multiple lobes of the liver. Advanced is it has gone beyond the liver. Okay, there is another system called child pug A grading, we say. How good your liver function is. That is based on whether you have jaundice, whether you have ascites, whether you are all whether you're unconscious because of the liver or in coma. We call it hepatic encephalopathy. There's another grading called just looking at simple factors like albumin and bilirubin. If your albumin is good and bilirubin is low, that means your liver function is good. If albumin is low, means liver is not working. Bilirubin is high, means you have jaundice. That means liver function is gone. So there are multiple staging methods to see what stage my disease is, how to classify very based on Barcelona system, based on child puke system. This a clinician will see how your normal functioning of the liver is.
Sir, in your clinical practice, like at which stage are Indian patients mostly diagnosed? In the advanced.
Mostly in advanced stage. By the time they develop symptoms, they have ascites, they have jaundice, or they have distribution of the disease in both lobes of the liver, or they have lymph nodes outside the liver, or it has spread to other areas.
So, sir, can you walk us through the conventional treatment methods which were there for hepatocellular carcinoma? Like, for example, the surgical methods that they used, or is surgery even an option for these patients now?
Very early disease, you will do surgery. If it is single lesion or 3 lesions in one lobe of the liver, less than 3 centimeters or 5 centimeters, and nor the remaining liver has normal liver function, then you will consider surgery. And if they don't have cirrhosis and chronic hepatitis B. But then there is something called liver transplant also. Again, they are done in those patients who are fit, to undergo a transplant who got a donor liver, but all these are in the early stages. Once you have distributed disease in both lobes, once it has spread beyond the liver, once the patient's general condition is very poor, then you go for systemic therapy. So, systemic therapy means treatment given for advanced cancer. When you treat advanced liver cancer, there is no chemotherapy. You will treat advanced liver cancer based on child puke status. They should be either child puke A or B, we say, B for Bombay. If your child puke C means your liver is gone, it is not functioning. So, no treatment is recommended for such patients. But if you are in child puke A or B means your liver function is reasonably okay, you will tolerate treatment. It is for advanced cancer, it is not chemotherapy. Now, the gold standard is immunotherapy combination or immunotherapy with targeted therapy. For those patients whom we don't give that for whatever reason, be it financial or anything else, they are put on some medicines called TKI, tyrosine kinase inhibitor. They are tablets. The names of the tablets are lenvatinib and sorafenib. So, some 15, 20 years back, sorafenib was the treatment for advanced liver cancer. Then lenvatinib was superior to sorafenib. It improved the lifespan by a few months. Then came the immunotherapy and targeted therapy. Atezolizumab and bevacizumab, the name of the medicine. If you give this combination, when compared to lenvatinib or sorafenib, people live longer. Then today you have a double immunotherapy combination, nivolumab, ipilimumab, or something called tremelimumab and durvalumab. Difficult to pronounce, but bottom line is advanced liver cancer is common, advanced liver cancer, no chemo. Either you give immunotherapy, if can't afford, go for tablets. Why are you doing this? To improve the quality of life, to reduce the disease, and prolong the survival. Uh, and in earlier stages, you are going to think of surgery, transplant, or sometimes certain procedures called TACE or tear. That is, they will put a tube or a catheter into the liver, into the tumor, and give some medication to shrink it. Sometimes they do it before transplant. They call it as a bridge to transplant, we say. So, very early stages surgery, transplant, very advanced stages, medical oncologist will take care based on giving immunotherapy or targeted or tablets that is based on the liver function, child puke A or B. If somebody is deeply jaundiced, somebody is in coma, somebody has so much ascites that it cannot be tabbed, somebody is so sick, unable to get up from bed, that patient you will not be treating, you will call them candidate for best supportive care or tender loving care.
Sir, when you talk about targeted therapy versus immunotherapy for hepatocellular carcinoma patients, which is better for the patient? Especially because now that we are in India, not all of the patients can afford the expensive medications. So,
Studies, data, science says immunotherapies and targeted combination is better than the tablets. But in India, I would only request if you cannot afford, don't go for these costly medicines. The reason being, if you buy for 3 cycles and then stop because of financial issues, there is no point. These medicines have to be continued if you get a response. So you have to give at least for 6 cycles. Scan. If the disease is stable, you have to continue. So if you cannot continue, if you have a very limited insurance or you can't afford, don't think about these medicines, go for tablets. We do have patients on lenvatinib and sorafenib doing well for 1 year, 1.5 year, 2 years, etc. Affordability not an issue, then go for these medications.
so the oral tablets, do they have any side effects?
Yeah. So oral side medications have mouth, you can develop mouth ulcers. You'll have a very sensitive mouth. Whatever you take, they feel they have a it feels like what do you say, spicy. Thyroid hypothyroidism can come. Their palms and soles will become dry and they may develop cracks. Diarrhea is common. Skin becomes pale in color. They may develop fatigue, weakness, loss of appetite. Liver enzymes sometimes can go up and down. WBC counts can go, hemoglobin can go down. So these are, but they are, and blood pressure will go up. So blood pressure monitoring is important. Thyroid monitoring is important. Avoid dry skin, be safe. For diarrhea, we give medications. We ask them to gargle their mouth and brush twice a day. Take all these precautions.
So, what are the side effects associated with the immunotherapy molecules?
Immunotherapy, same way, can cause fatigue, can cause hypothyroidism. The liver and pancreas enzymes have to be checked. They can cause dermatitis or colitis. Diarrhea can happen. They can have dry skin, and sometimes it can be very severe. You may need to give topical steroids or even oral steroids sometimes. So these are the common side effects of immunotherapy.
So, is there a chance that a patient can be getting the oral medicines plus the immunotherapy? Is this a
That is very
combination?
common in kidney cancer. We do that. In renal cell carcinoma, we give TKI plus immunotherapy combination. But in HCC, we generally don't do that.
So, how is the quality of life of these patients who are diagnosed with HCC?
See, one thing is fatigue is an issue. Weakness is an issue. Appetite will be poor. That's an issue. And frequent ascitic tapping. They have to come and remove the water. But if the disease responds, then they are usually okay. They're able to do their daily activities. Pain is not such a concern. Uh, so they'll be able to manage.
So, compared to 5 years before, would you say that the treatment paradigm and the survival for patients has improved now?
No doubt, madam. When I passed out in 2013-14, only sorafenib was there. Or lenvatinib had just come, I believe, if I remember right. In 18 or 19, you had atezobev. Now you have dual immunotherapy combinations. You have nivo-ipi. You have single agent immunotherapy in those patients who cannot tolerate double agents. So definitely quality of life has improved, lifespan has improved, survival has improved. So it is improving. But again, uh, those factors or the common factors or the causative factors have to be taken care of so that we don't develop liver cancer.
So, what are the lifestyle advices you give to patients who are diagnosed with this cancer?
Healthy diet, high in protein, less in salt, small, frequently spaced meals, avoid spicy food because of the changes in your mouth. And that's about it. And if you have ascites and all that, your doctor will ask you to limit water intake to 1 or 1.5 liter a day.
Sir, what message would you like to share with the public on basis of prevention, then early detection, and maintaining liver health?
No alcohol, vaccinate against hepatitis B. If you're having hepatitis B and C, meet a gastroenterologist and start on antivirals immediately. If you have chronic hepatitis B and C or cirrhosis, do an ultrasound and an alpha fetoprotein every 6 months. That is screening for liver cancer. If you have a history of liver cancer, again, keep screening yourself or be under regular follow-up with your oncologist. Healthy lifestyle, no obesity, so that you don't develop a non-alcoholic fatty liver disease. And that's about it. So prevention is no alcohol, healthy weight, uh, no hepatitis B, C, vaccinate against hepatitis B. If you have hepatitis B, C, be treated. If you have hepatitis B, C and cirrhosis, regular 6 monthly ultrasound and AFPs.
Sir, could you enlighten us about the second opinion campaign that you are running?
So as you know, we have a second opinion campaign. We want to reach out to people who are in need of an opinion where they don't get an opinion, even maybe due to geographical area. So if you have a cancer patient whom you don't know how to go about, reach out to us. It's free, and we'll WhatsApp you what we can make out from your reports and guide you.
Thank you for this informative session on hepatocellular carcinoma, and we hope to see you again next week with another enlightening session. Thank you, sir.
Thank you so much. Bye.